So hello and welcome. I'm Hannah Lewis. I'm EPIET alumna from cohort 12, which is 2006. I'm really happy to be here after missing many escades, so I'm really happy to be back and seeing so many familiar faces. I'm now a consultant with WHO headquarters. So welcome to our session, Are We PRET for the Next Pandemic? I'm joined on stage by Isabel Bergeri, Technical Officer, and Gina Samaan, Unit Head of Pandemic Preparedness Global Platforms at WHO Headquarters. Also by Adam Roth and Alma Toston. Welcome, and thank you for joining us today. Some sessions have already touched on pandemic preparedness, such as Bar Camp last night and the plenary this morning. And we wanted to take that discussion further with you. We want to discuss with you the future, the next era of pandemic planning. Questions such as what can we do to be better prepared? How do we move ahead with what we've learned from COVID-19 and other emergencies? At WHO, this body of work comes under the Health Emergencies Programme. In terms of structure of this session, you're going to be hearing very briefly from us at WHO HQ. We're going to keep it as short as possible so that we have time to hear from our panelists and also to have an open Q&A session at the end. Finally, for the Q&A, as said at all the sessions, please put your questions into the question box and use the chat just to say hello and for comments. So first of all, I'd like to hand over to my colleague Isabel for Slido.
So, because I'm not that good as Steen, for example, for having not used the help of Slido, I will use Slido, but bear in mind with me, I will try to be as an entertainer as she is, because thank you for you who have stayed till Friday afternoon to this session. So please scan the codes here. And just bear in mind also there will be a 30-second lag for the people who are online. So we'll start also the discussion while we are waiting for their answers. I see still some mobile phone up, so I will wait for everybody to have made the survey on their phone. Okay, last chance. Okay, please, no? Slowing down, okay. Oh, the question is already there. So first, this one is very easy, but we wanted to a bit gauge the audience, both online and here. Please let us know if you are a field epi or public health microbiology trainee, if you are a public health scientist or epidemiologist, or if you are a bit in the much more managerial position as a public health manager or policy advisor, or if you are an FATP program director or an academic. And some of you will tick others, or all of them, or some pieces of them. So here we wanted to a little bit know about your current position there to be able to really target and be able to answer much more to your question in a very targeted way so that you can also understand what we think could be the next the new area of pandemic preparedness planning here. And looking at the audience here and trying to recognize faces, I think we may have 30% of field epi people here. I hope I will be right. We'll see how it goes. Yes, you can show the results. Okay, I was wrong, but okay, go back to the answer. So welcoming 50% of public health scientists, epidemiologists, and I think thank you for all the others, because I think for a large proportion of us who are more than 40 years old, wave your hands, we are all in these categories here because we have had several, let's say, background and also several experience, which is really good. And I encourage everybody to do that. So thank you also for all the manager and program director here that are in the room, because most of the job and the decision making on how we will address the post-COVID phases will be in your hands. Next question, please. So, were you involved in the COVID response? Please tick those boxes. Normally 90%. Let me see. I see people nodding. And also, it's not because you were perhaps not involved in the COVID response, because you were perhaps just a trainee and you needed to perhaps much more support other programs for business continuity or whatsoever, that be ready for the next respiratory pandemic because it will come. Normally, it's every 10 years. So this will be your role next time. Is it good enough for the responses? We'll see. Easy. Okay, I think we have had different experiences to COVID, but we'll try to summarize what are the main, let's say, area of work we have identified from all over the world. Next question. So now it's a word cloud. So in 1 or 3 words, what worked well in the public health response to COVID-19? So we want to take it in the optimistic way because we've heard a lot about what has not worked, but I think we are sometimes not good enough as human beings to see also what worked well. So please put any kind of quick words on what you think has been managed well, or what were the innovation you feel like has happened, or even just the basic human relation that has been built during COVID and you will want to see maintained, anything related also to your, for those who are trainees, anything you have seen that was really well done during this, the response to COVID-19. This one is a bit longer. You need more time for the people online. Yes, you need more time. And I hope we will get some trends in there, sometimes not, but I feel because we are quite an audience that seems to have kind of same background, we hope we can extract some trends here. Yes, please go ahead. So let's see. Okay. I think there is some bias here. I see the vaccine or random vaccination positively. This is a positive bias here. And collaboration, again, this is sometimes something that is not measured, that is perhaps not enough valued. And we hear a lot about the bad experience of the problem. But I mean, it seems like overarchingly, you feel like this COVID pandemic guys show that we can work collaboratively together, that we were supporting each other in some especially perhaps some scientific area and whatsoever. What I see that is a bit something that I was not expecting. WhatsApp technical group, okay, no, this one is not that surprising. Anybody has something controversial here? I see people, no, I don't see certain person here. Modeling, speed, mitigation, good leadership. This is of paramount importance, and we'll tackle that later on, multidisciplinary working. So I think this multidisciplinary working, we'll go back to that one later, but this is really globally, at the global level, this is really something that will be the target for improvement in the coming years. Next question is the last one. Okay, a much more controversial one. I forced it to be added. Some people didn't want it. And be honest, we are here really to debate on that. Do you think pandemic preparedness works? Not everybody has the same definition of what means pandemic preparedness, but this is also something we will tackle. Gina will try to enlighten you about. And be careful, the one who are saying not sure, they might have to come to the stage. No, I'm joking. I'm sure Alma and Adam will be able perhaps to give some perspective on those ones. Yes, please. So pandemic preparedness works for 50% of the audience, but it doesn't work or people are unsure for the other 50%. So really here, there is a divergent opinion on here, but I think let's move ahead and also perhaps try to explain to you what can be the solution to why some people feel like preparedness doesn't work, or the investment that we made in preparedness hasn't paid enough in terms of return. So thank you very much, and now I pass over the floor to Gina, who will respond to all the possible questions. Thank you.
Colleagues, it's a pleasure to be with you. First of all, thank you to the government of Spain for the wonderful venue, to EPIET and the group leading this wonderful conference. I've never attended this conference, Escaide, before, so it's a real privilege and pleasure to be with you. So I'm Gina. I have the more difficult job that Isabel has asked all the tough questions, and now I'm at the helm of trying to address some thoughts and get you thinking about how we think about pandemic preparedness moving ahead, the new era in pandemic planning. So it's a play on words, getting ready for the next pandemic, get PRET. First of all, a definitional issue. What is pandemic planning? And so to be quite clear of how we use this, it's the continuous process of defining, exercising, implementing, and updating, reviewing the actions needed for preparedness, pandemic preparedness, and response. So this is a very general definition, and critically about these operative words: defining, exercising, implementing, and updating. With that question, does preparedness work? And this is one of my favorite examples to show that preparedness does work. In the African region, countries that participated in influenza surveillance, really with the focus on pandemic readiness, pre-pandemic, pre-COVID-19, were significantly faster at introducing SARS-CoV-2 testing in their countries than those who did not have influenza laboratory-based surveillance. Preparedness works. And it's just an absolutely wonderful example in my mind. Preparedness works. Pre-COVID-19, there were these epidemiological investigation protocols for influenza, again, with the learnings from the earlier pandemic, that we need to have ready protocols to go on understanding seroepidemiological parameters of a new pathogen. Those influenza protocols were developed in 2018-19, and Isabel is an expert at this, a real leader in this field. They were quickly adapted for COVID-19 at the time of that pandemic. Preparedness works. So, what else is this about? Are we just redoing what we were doing anyway? I guess this was the topic of last night. Are we covering the basics, or is there something new? There are pieces that are new. Infodemic management. How many of us had heard of infodemic management prior to COVID? I'm going to argue very few. The social digital listening that came in a big way during COVID is also something new. So there are innovations we have to think about building into our future plans. So we're taking all of these learnings. We've looked at all the reports and the lessons and the country evaluations. We've kind of distilled it to 4 key messages. Preparedness works. Health is everyone's business, i.e. whole of society. Thirdly, we're all at risk if we all have to be safe, for everyone to be safe. So no one is safe until everyone is safe. It's about the vulnerability and who's at risk. And fourthly, response has to be adaptive and agile. You're constantly adjusting, so there really is no rest in this work. So what we now have to do is to say, right, here are the core messages, here's what we've kind of distilled in terms of learning. How do we put these into action looking ahead to prepare for the next one? And why are we talking to you about it? Particularly epidemiologists played a critical role during the pandemic. And what analysis after analysis from country level, at global level, at regional level have shown is that epidemiologists were involved in everything from A to Z. Even when vaccines became available in the second year of the pandemic, epidemiologists' role shifted to logistics, deployment, micro-planning, and so you could see the evolution and the breadth of the work that we do. So, really this is about two themes. The first being about have many risks, we need to prepare, and really us, as the people involved in all of it, the superstars of the preparedness and response cycle, we need to get ready. So the two themes are PRET, to share with you how we see pandemic planning moving ahead, and secondly, that we need to be sure that we are all fit for purpose and ready to take that on. So what is PRET? A new approach to pandemic planning taking a mode of transmission lens, preparing for groups of pathogens. And why do we do this? We're looking at it for efficiency. The concept was launched in April this year with a call to action that had 3 key messages to global stakeholders. 1, update your plans. 2, let's think of it in a whole society way. And 3, let's sustain the resourcing and the attention to it. That is our call to action. This is modular because we're working by mode of transmission, right? So we have to think, well, what's our first mode? We thought the first should be respiratory pathogens, probably an obvious one to all. And this is why respiratory pathogens is module 1 for now. What does the module give you? It's guidance. It explains the why, the what, and the how. So really, it's trying to get to that operational level of how we take those learnings and translate them into the how. We have an organizing framework in that, the pandemic operational stages and periods. And the reason to provide this is that we all, in our own contexts and settings, are organizing ourselves in a similar way. Why is that relevant? Coherence. If we're talking the same language across countries, it helps us align and think about what actions happen when we first detect a new pathogen. We can talk about what we do when there is global disseminated spread with multiple waves. It helps us talk the same language. All of this, of course, steeped in continuous surveillance, risk assessments, and of course the underlying foundation of communities being at the heart of the work, multisectoral systems, all being at the core. What the PRET module does as well is articulate the interdependencies. 15 different sectors are critical to us in terms of pandemic planning. So it's easy to identify what do we do with them. So where are our touch points? And we think, again, field epidemiologists can play a role in leading these conversations forward. How do we work with the education sector in preventing, preparing, responding, recovering? And again, taking us through it together systematically. PRET, in terms of preparing for groups of pathogens, is looking at subsystems for emergencies, what we call the 5 Cs, from surveillance, collaborative surveillance, community protection, and all around, as you can see in this circle. And all of that with underlying foundational systems as we've defined in the international health regulations. So we've tried to map this out to make it simple, logical, operational, to help us think about what we prepare for each. So examples of how this fits together, because we get asked, well, how is this different to my National Action Plan for Health Security? That's a preparedness looking at the foundational systems and core capacities, but you've got these specific pathogen groups work that we need to do also. So it's about this hazard approach that we need to plan and prepare for. So here's a good example. In the space of collaborative surveillance, our broader foundational systems would have a national and subnational laboratory system. When we think about it in terms of the hazard, so for respiratory pathogens, our system has to have a virology lab for respiratory panels so that we can look at pathogens in a systematic way. Then the pathogen-specific within it is, for example, having a national influenza center. So this is the sphere of operation when we think of pandemic planning by mode of transmission. Another example is the clinical care system. So Countries have clinical care capacities, health service delivery. Within the respiratory hazard group, it's about having the right SOPs, the right resourcing, the guidance to enable that body of work to take place. And then, of course, for specific pathogens, there are the specific countermeasures required. And what we're seeing overall is generally an increasing tendency to make it more efficient by looking at our systems in an integrated way. So surveillance for respiratory pathogens as a group, social digital listening for acute respiratory infections as a group, so that it is efficient and capturing what we know, the influenzas, the coronaviruses, but also potentially what we don't know, the pathogen X. So here are the examples of how we see this fitting together and how we have to talk about the hazards, but also within the context of the broader foundational system. Plenty of resources and tools are available to you through PRET. Desktop simulation packages, exercises to help us think and review our plans. There's a community of practice being established, so you can join this community of practice to share your resources. And we hope next year to start hosting events and exercises through that community of practice, engage in discussions and threads, and to really connect with that community. With countries now having started to implement since April the launch of this new revised approach to pandemic planning, we're seeing lots of activities in countries. And we've now had 7 months of rollout and reached 93 countries. And what's resonating are a few messages. The mode of transmission approach is working. It makes sense to people. Talking about the gains made during COVID is a good starting point of the conversation. We have plenty of gaps, we all know, but talking about what works and building on that is helping us lean into updating plans. Focusing on the routine systems that we use day to day, that are the foundation of what we do, is also helpful, so we're not building new. And bringing in supranational bodies, regional bodies, global bodies, to help with systems and capacities or conversations that are more difficult at the national level also is useful. So a good example there is how pandemic planners in ministries interact with civil society groups, the Scouts, the youth associations, one can go on. But the point is, if we can do this and start to have the discussion at the global level, regional level, this may give ideas to the national level planners. What's enabling? We're triggering the conversation quickly, soon is important, because we're starting to lose that muscle memory, the fatigue, the turnover in staff. So we want to capture that before we lose it. Secondly, partner engagement. All the partners that you can think of in pandemic planning, engaging them early is critical. Third, peer-to-peer dialogue. So countries working with each other, learning from each other, the pandemic planners talking to each other has been incredibly helpful. What's challenging is the multisectoral engagement. How do we keep them with us? And also a fast evolving context at national level. Changing institutions, changing human resources and strategies is a challenge. So, what about the field epidemiologist's role in this? As mentioned, lots of analyses from lots of countries saying what a big role they play. And so really thinking for us as a program in pandemic planning, getting ready, epidemiologists, what do we do to have a PRET workforce? So we do need epidemiologists to engage in this space and who can competently coordinate and work across sectors and deliver plans. And we think that we can also work together to better prepare future generations of epidemiologists and current generations of epidemiologists by working together and having these communities really be effective at co-collaborations. With that, thank you for your attention, and over to you, Hannah.
Thanks. Thank you very much, Gina. We have one question in the chat that's specifically, I think, good for you to answer. So, Isabel, over to you.
Yes, Gina. people think we need a really deep analysis of what has worked and what has not worked during the COVID pandemic. So you presented one of the slides, gathering all the possible review. Can you tell us a bit more and highlight some much more perhaps area of work that were of concern, things that have not worked and things that have worked?
Oh, there's many, and it depends on who you're asking. So I think at the macro level, there's been analyses done by the International Pandemic Preparedness and Response Review Board, IPPR, its acronym, looking at various elements of the response, and some key issues that arise from that are focusing on equity in terms of at-risk populations. So looking at equity from a public health lens is one lesson learned, and how to do better in that space. Another is about the pathogen X. We had, prior to the pandemic, Isabel, 92 countries had influenza pandemic preparedness plans. And many quickly refurbished those plans to use them for the COVID-19 response, which is great. But our plans now have the opportunity to also account for that pathogen X. So here's just a couple of examples of where learnings have helped identify gaps to help us think ahead.
Gina, another one. Why are you only speaking about perhaps respiratory viruses, pandemic preparedness?
So we're not, in fact. So we are talking about respiratory pathogens at large. Different subsystems, for example, in surveillance, there may be surveillance for respiratory viruses based on the molecular techniques available, and virology labs are established. But in essence, we are trying to keep a wide lens by looking at respiratory pathogens at large. You deal with different subsets of those pathogens in different ways, but the concept is to have a wide lens.
Thank you very much.
So we do have also a couple of questions more specifically about the fellowship program and FETP, but I think what we'll do next is turn to our panelists, because we have two expert panelists here who are going to make some comments, and then after that we'll come on to those more specific questions. So first I'd like to turn to Alma Tosman. You're EPIET alumna from cohort 2009, and also ex-vice president of the EAN board, Ian. Currently you're an infectious disease epidemiologist and deputy head of a large academic medical center in the Netherlands. So my question to you, please, if you could turn back the clock to before COVID-19, what skills would you have wanted fellow alumni, both epidemiologists, public health microbiologists, to have to better manage this devastating pandemic?
Thank you, Hannah. So first of all, I'm not the deputy head of the whole hospital, but of the infection of the infection prevention and control unit. So if I could turn back time, when the pandemic started, I was 39, and I had just been in my job for a year. And one of the things I had to do when COVID hit our country, we were already preparing in our clinic for all the things we had to prepare in terms of PPE for the staff, etc. Is that I have a team with 7 infection prevention specialists, and they do a lot of things, but also a lot of contact tracing in the hospitals. And within a few days, we realized we need more of them, but of course they are not there. So we needed support staff. And we got about 6 students, medical students. Their training was put on hold, and they were available to help out all over the hospital, so also in my unit. And I had my colleagues running around, I'm so busy, I'm so busy. And I said, well, I have here these students. What can they do for you? I don't know, because they were too busy to even think. So it was my task to sort of find out like what kind of tasks I could get out of them. So I had another colleague sort of shadowing a colleague to see, and she wrote down, okay, this can be done by students, this can be done by students. So at the end of the day, we had a whole list of things these students could do. But this was very stressful, and we were really, pragmatic, and it worked, but I really wish I had thought about how you scale up your team and your role. And for me, it was specific in the hospital, but I think it is quite generic for all of us here in the audience that whatever we were doing for those who were involved, it had to be scaled up, and how to go about it. And I had never thought about that before. Maybe it is part of some planning in my team, but I don't know, I was just there for a year. So I guess that's one thing. And I had to set up surveillance, but that went relatively smooth. And I had a lot of media encounters, which I really enjoyed and for which I was supervised very well by our communications team. So for that personally, so my need was mostly about this upscaling, the thing that you do. Yeah.
Thank you very much. And now I'd like to turn to Adam, you're head of the ECDC Fellowship Programme. You must always be thinking ahead about workforce needs. Does the current fellowship programme curriculum meet the needs for pandemic planning? And what feeds into the decision to update the curricula? Thank you.
Thank you, Anna. Yeah, that's a great question, whether we meet the needs. I think that's something we're working a lot on. It fits very well currently with what we are currently updating the curriculum of the fellowship, and this was a process that was started also before the pandemic, but of course the pandemic feeds into this to a great extent. And there are currently, just Tuesday, we had a discussion for a whole day around this, about the curricular update in general. But one of the main discussions was really to what extent our preparing for the pandemic and to what extent preparedness should influence our curriculum. And so this was a discussion with the network, that the people at the training sites, the supervisors and the national focal points for training in Europe, which are really the main people, apart from the fellows, of course, for the fellowship. And we haven't landed there yet. It's a discussion where we are really going into what is really the core of the fellowship, because what we feel strongly is that the DNA of the fellowship needs to be there. We need to have because that is actually what is pandemic preparedness, a bit like what you said. I mean, surveillance, outbreak investigation, being able to do applied research, communicating. This is really things that has to be in the workforce, and that's where the field epidemiologist needs to be best. So to what extent should we also then start working with more setting this into the context of preparedness as such? And I think everybody agrees that is fine. It's just that we're afraid of watering out the curriculum. So somehow we need to land there. Then the way that we are tackling this in the new curriculum is that we decide that some parts are core for field epidemiologists, and some things will be elective. And that means that we can have our competencies to a lower extent, and then you could also have competencies to a higher extent. And we don't want to fall into the trap where we have lots of topics that we just talk about, because this is clearly, all field epidemiology training is really in service aspects. So we want fellows to be able to do projects within this. So in the end, we're going to land somewhere, and we're going to try it out and see what will work out the best for this fellowship. But the needs are clearly very different in both in Europe and also in the countries lining the EU that are part of the MEDEPIET fellowship. So I think we are probably going to land in that we have a basic understanding of some of these issues, but that we have an elective, and depending on the need of the fellow and of the country, where fellows are going to step in and do some real preparedness work, so to say. For instance, an after-action review or taking part of an assessment of the country, etc. Hopefully, then these kinds of projects will be very hands-on. But we are already doing. I mean, risk assessment is a clear part of the curriculum. Risk communication, understanding the workings of an EOC, for instance. These are already important parts of the fellowship, and will continue to be. Thank you.
Thank you very much. So we have just under 10 minutes left of the session. I'd really like to encourage those in the audience to post questions, please, for everyone who's here, both our panelists and for Gina. And I will hand over to Isabel for some questions that we've already got in. Thank you.
Yes, so I will highlight first a comment because I think it's summarizing a bit well some other examples we've not touched here. The thinking is about that the overall routine surveillance system need to function well and not concentrate only on this shiny object, or not to have resources targeted only the new shiny object. And the comment was really what has not work well and what we should plan ahead is like the recognition at political level of existing service and how they work. So kind of on an education of our policymakers not to reinvent the wheel and base all our search management on that. There is a question, but I think Adam has responded to it. So there, Arnold, do you want to take the floor? You are posting so many questions. Thank you. Arnold, go ahead.
Normally my voice is Thanks so much. I think this is a key discussion, and also thank you for bringing the PRET context so good on the floor. The key question that I have is the concern that Adam already elaborated on. The 2-year training program curriculum is already so packed with technology that is a must for a field epidemiologist. And what we hear back from all the exit interviews of people after the training, not just after the graduation, but also 5-10 years later, they look back at the training and say, never ever in my professional career have I had so much dedicated time to really focus on epidemiology, to understand methods. And if that is something that you are watering down by adding competencies that are not really core to field epidemiology, then you're never going to get back that type of competence, no matter how long after that you're going to work in the field. So I'm really concerned that now there seems to be, and that's why I'm asking you, can you be very smart in your expectation of what you want of an FETP to really contribute to preparedness? Because this will also probably eliminate this fear that we have, and that actually I also have in this stage. Because we know that FETPs are really very visible and very attractive. And I've seen a lot of initiatives say, oh, but then we need to put this in it, and leadership. And we had a lot of discussion with ASFER when we were writing the new set of core competencies for field epidemiologists in Europe. Now, subject B in the core competencies is all about preparedness. And that part of the preparedness is, how can a field epidemiologist make sure that we're prepared enough for the next outbreak investigation, for the data collection, for the data analysis, to use the new technologies like bioinformatics, the new data collection systems. If we're talking about that type of preparedness, I think a lot of our anxiety will be reassured, because that really touches the core of our being, of our professional being. But if we're talking more about something that we see like what Alma was referring to, like, you know, we all suffer from an organization where search capacity is not well managed during a crisis. But that, for me, that is not a responsibility of a field epidemiologist. That's the responsibility of a crisis manager. And you have specific crisis manager training programs for that. So I think when we're talking about changing curricula, we have to be really very careful about, you know, how we protect the value that we've built up in the past 30 years. Thank you.
Hannah, can I maybe have a stab at this? Yes, thank you, Arnold, for the comment. And indeed, the adage goes, if you throw something in, something has to be thrown out, right? So it's a question of, let's have the discussion to see, is that necessary? That's the question. So what we've seen from the pandemic is field epidemiologists really did, and the analyses done looked at the pillars of response to COVID, and there were generally 10 pillars in the discussion. And that epidemiologists participated in nearly all of them. Interestingly, from country analyses in Papua New Guinea and Australia, it was very clear that the leadership role that field epidemiologists played in senior positions was also very much acknowledged as a contribution of field epidemiologists during the pandemic. And so this is an important discussion, because where you are thinking about, well, if it's not part of the core, because the core has to stay, where is that? And we know field epidemiologists are in the business of pandemic planning and response. Where else does this go? Where else can we equip people to have those relevant skills, competencies, etc.? Or does it remain on the job? Those who go into the space are practicing and therefore learning by doing in the job. So this is the discussion we're having. And the reason is the health workforce is constantly changing in its nature. The workforce needs of governments are constantly changing, and the competencies defined by governments. Many have moved away from having vector control specialists, entomologists, for example. Countries have lost their entomological workforce and now saying, hold on, actually, we need to revisit the strategy. So it's an important conversation to have, even if it doesn't land in the core of a program.
But I'm also here to represent the EPIET alumni network as a current board member. So I was just giving a personal example, but I think taking the perspective from the alumni network, I mean, as a fellow, you learn your core things, but then of course there is this whole afterlife to which you still have time to learn new things. So I can also see how skills like more the leadership skills are more important if you grow towards a more senior position, and they fit perfectly well in, I guess, the post-fellowship life, doesn't it? Where you are more in need of those skills. So then everything does not have to be put in those 2 years. What do you think?
Yep.
No, I definitely don't think everything has to be put into those 2 years. But I do think there are certain aspects of leadership that definitely has to be in there. So, but I don't think we should deal with management, for instance, with fellows at all. But I think most fellows are very happy to talk about how to give feedback to each other, for instance, and also working more how to manage, for instance, what we talked this previously, manage stress, etc. So it depends on what you put into that definition. But I wouldn't. I would also totally agree with that, and that I think. What was mentioned also by Arnold there, the looking at the framework that was put together by ASFER, that was an enormous framework in terms of what an epidemiologist should do, and comparing to the competencies that we are proposing, it's a very, very much more limited and focused competency framework that we're working out. But I think it's an incredibly important discussion, and I agree with most of that, I would say.
Thank you very much. We've actually got a couple of questions as well that are quite linked to what you just said, Alma. So at least 2 people in the chat have commented more in the direction of, is this something more for post-fellowship? Is this something for continued professional development of FETP alumni and the wider workforce? I don't know if any of you would like to comment on that.
Yeah, I agree. It reflects a bit to what I just said, that if you have done a fellowship and you've learned your skills that are, of course, already on top of all the other skills that you had, I think there is so much time to, really go and think and look for the thing that you still need or want to develop on communication, leadership, or, in our EAN member survey article, we also have a chapter on COVID, and there also these things are really mentioned specifically by alumni who are, of course, in all different phases of their post-fellowship life. So,
thank you. Adam, do you have a comment on that specifically?
Yeah, I think it has to be that kind of relationship, but also realizing the different fellows. I mean, even though we try to get a fellow decently aligned, but there are very different levels also of fellows coming into the fellowship. And looking at what some fellows and sites manage to do during 2 years of fellowship can be 10 times less than what another fellow manages to do. So whether and that's what I think there needs to be, that kind of flexibility as well, where a fellow and a site that wants to go into one project that is relevant, whether it's be it in leadership or be it in preparedness or be it in very advanced modeling, that should also be a possibility, because it's not one size fits all completely, even though, of course, the core has to be the same.
Thank you very much. I see we're out of time. I just want to ask Gina if you want a last comment before we finish, please.
Thank you, Hannah, and thank you, Adam and Alma, for the inputs today. This is very helpful to us because we need you, and we hope that in this way it's opened the eyes to the new world of pandemic planning in a new era post-COVID, and we really have appreciated the inputs and conversation around pandemic planning and the workforce that underpins it. With that, thank you.
So thank you very much, everyone, particularly those of you who've stayed here quite late today. Thank you. And yeah, we'll be around if there's any further questions.